Good afternoon, everyone. Thank you for joining us today at this wonderful event, community event, Health Matters. My name is Sandra Ben-Efraim. I am a local resident and a member of the Stanford Medicine Community Council. Thank you again for coming today. Thank you. And before we start today, I do want to remind you that if you would like to participate and ask questions, we are going to be doing this via the QR code. So if you're participating live, you will find the QR code in your program, or if you're online, it will be on your screen. Okay. I hope you've been able to enjoy the informative sessions earlier today and that you will find the session, Pain, Pleasure, and the Addictive Chase for Dopamine, to be highly educational and insightful. I am now pleased to introduce you to Dr. Anna Lembke, who is a professor of psychiatry and behavioral sciences at Stanford University School of Medicine, chief of the Stanford Addiction Medicine Dual Diagnosis Clinic, and the author of the best-selling Dopamine Nation, Finding Balance in the Age of Indulgence. Dr. Lembke is an expert in treating addictions of all kinds. Today, she will share with us the biology and psychology of why people become addicted to certain substances and behaviors, and the key role that our dopamine levels play in creating addiction. Dr. Lembke will also explain how to conduct a dopamine fast in order to help curb our innate desire to overindulge, be it with drugs, alcohol, food, work, the internet, and the list goes on. Lastly, she will share how to find contentment and connectedness by keeping our dopamine in check. Please help me welcome Dr. Lembke.
Well, thank you, everybody. I'm so honored to be here. I want to thank the organizing committee for putting on such a great event against all kinds of odds. And I'm thrilled to see so many people here in person today. So what I'd like to do in the time that I have is first talk about how our brains have evolved over millions of years to process pleasure and pain, and how those ancient neurocircuits are mismatched for our modern ecosystem and what the result is. And then finally, how we can apply our understanding of the neuroscience to our modern lives to increase our ability to flourish in our dopamine overloaded world. So let's start out first by just talking about some of the most exciting discoveries in neuroscience in the last 50 to 100 years. And the first is that there is a dedicated circuit in the brain specifically for pleasure, motivation, and reward. And you can see it here, represented here on the screen by the ventral tegmental area and the nucleus accumbens, where neurons release dopamine, our pleasure neurotransmitter, in communication with the prefrontal cortex. The prefrontal cortex is that large gray matter area right behind our foreheads, which is so central to delayed gratification, future planning, and all kinds of things that help us put the brakes on dopamine. For those of you who may not be familiar with some of this terminology, neurotransmitters are essentially those molecules that allow our neurons to communicate one with the other. So we have presynaptic neurons and we have postsynaptic neurons, and between them is a gap called the synapse. And neurotransmitters are the molecules that bridge that space between neurons to allow for fine-tuned communication. One way to think of that is to imagine that the presynaptic neuron is the pitcher, the postsynaptic neuron is the catcher, and dopamine is the ball that the pitcher throws to the catcher. Dopamine is the neurotransmitter that is most intimately associated with the experience of pleasure, reward, and motivation. Now, it's not the only neurotransmitter involved in those processes, but it's probably the final common pathway for all reinforcing drugs and behaviors. And a wealth of animal studies over the past 50 to 75 years has shown that different types of drugs increase dopamine above baseline by different amounts. And we do believe that the more dopamine that's released in this brain's reward pathway and the faster that it's released, the more addictive is the substance or behavior. And you can see here a summary slide of what happens in rodents when they're exposed to certain types of drugs or behaviors to their dopamine levels. So a really important point here is that dopamine is always being fired in our brains at a tonic baseline level. So what the brain is looking for is changes in dopamine firing around that tonic baseline level. And when we have an increase in dopamine firing, that is highly reinforcing, and that tells us to approach. And when we have dopamine firing that goes below those baseline levels, that is dysphoric or unpleasant. That tells us to do something to change our circumstance to get more dopamine. Now, a concept that is not reflected in this slide, but I think is really important to consider, is the concept of drug of choice. And what that means is that different people will have different amounts of dopamine released in response to different drugs. So, for example, what may release a lot of dopamine in my brain may not release as much in your brain, and vice versa. And that becomes really relevant for understanding the world that we live in now, because not only do we have more and more potent forms of traditional drugs, but we also have new drugs that never existed before. And that means that the susceptible population on the planet Earth for the problem of addiction will grow, has grown, is growing. The example that I talk about in my book is my own addiction to romance novels. I had long thought that I was immune to the problem of addiction. My father was a high-functioning alcoholic, but I thought somehow those genes skipped me. But somewhere along in the middle of my life, I discovered the Twilight Saga. For those of you who don't know, that's a vampire romance novel written for teenagers, and it absolutely transported me. I read the whole series 4 times through. Then a friend recommended to me that I get a Kindle. Getting that Kindle was crucial from transitioning me from recreational romance reading to addictive romance reading. All of a sudden with the Kindle, I had easy, instantaneous access to highly reinforcing books that I could now get for cheaper and cheaper amounts. I could get them even for free. Amazon, like any good drug dealer, knows the value of a free sample. And over time, I indeed found myself spending more and more time reading, wanting to escape into that fantasy life. And here's a really important piece. Over time, I developed tolerance to my drug. What does that mean? That means I needed more of my drug and more potent versions of my drug to get the same effect. So I progressed to tame vampire romance novels written for teenagers, to frank erotica like 50 Shades of Grey. And I would say that my bottom was when I found myself at 2 a.m. reading about butt plugs and wondering to myself, what on earth am I doing here? So we laugh and we make light of it, but indeed it did impact my life. And the definition of addiction is the continued compulsive use of a substance or behavior despite harm to self and or others. And of course, I would never want to trivialize severe life-threatening addiction by comparing my experience to that of people who are suffering from terrible and life-threatening addictions. But I will say that even as an addiction medicine specialist, I think that I was teetering over into harmful, compulsive overuse. I was not getting enough sleep. I was starting to ignore my kids. I certainly had begun to ignore my husband. I was going to parties with a romance novel in my pocket and actually escaping to rooms to read instead of socializing, and even bringing romance novels to work and reading between patients, because I found then that my real life experience began to lose salience. And this is a really key piece of the trajectory of addiction, that our focus narrows, that more modest rewards become less interesting to us, that things that used to be really interesting and rewarding get leached of their salience, and the only thing that makes us feel good is our drug of choice. And I want to talk a little bit about what's happening in the brain when that occurs. I will also add that dopamine is important for movement, right? We know that Parkinson's disease is a disease characterized by a depletion of dopamine in the substantia nigra, which affects movement. And it's no coincidence that the same neurotransmitter that's important to movement is also important to pleasure, reward, and motivation. Because for most of human existence, we have had to get up and go work to get our reward. And again, that is no longer true. So to understand how our brains process pleasure and pain based on really exciting neuroscience that we've discovered in the last 75 years, imagine that in that part of the brain that has that reward circuit, there's a balance, kind of like a teeter-totter in a kid's playground. When that balance tips to one side, we experience pleasure, and when it tips to the other, we experience pain. But there are certain rules governing this balance, and one of the most important rules is that the balance wants to remain level. It doesn't want to be tilted very long to the side of pleasure or pain, and our brains will work very hard to restore a level balance after any deviation from neutrality. That means when I read a romance novel or eat chocolate or watch American Idol YouTube videos, I get the release of dopamine in my brain's reward circuit, and my balance tilts to the side of pleasure. But no sooner has that happened than my brain begins the work of down-regulating my own dopamine transmission, down-regulating my own dopamine receptors to bring me level again. And I like to imagine that as these little neuroadaptation gremlins hopping on the pain side of the balance to bring it level again. But here's the thing about those gremlins. They like it on the balance. So they don't get off as soon as the balance is level. They stay on until the balance is tilted an equal and opposite amount to the side of pain. That's the come down, the after effect, that moment when I reach the climax of the romance novel, put it down, and immediately want to start reading another one. If I wait long enough, those gremlins hop off and balance is restored. But if I continue to bombard my reward pathway with highly reinforcing drugs and behaviors, I accumulate more and more gremlins on the side of the balance. What does this mean? Now I need more of my drug to restore homeostasis or to get high. I need more potent forms of my drug. I need more variety in my drug. And if I continue in this pursuit, I eventually end up with gremlins camped out on the pain side of my balance. This is the addicted brain. What's happened here is I've changed my hedonic set point. Hedonic is joy. In my pursuit of pleasure, I have essentially decreased my ability to experience pleasure and increased my baseline state of pain. Now I'm walking around with a balance chronically tilted to the side of pain, which means what? It means I need to use my drug not to get high, but just to level the balance and feel normal. And when I'm not using, I'm experiencing the universal symptoms of withdrawal from any addictive substance, which are anxiety, irritability, insomnia, depression, and intrusive thoughts of wanting to use. This is a very famous study by Nora Volkoff, the head of NIDA, and her team, looking at dopamine transmission levels in healthy controls, which are the brains on the left-hand column. And in these images, red equals dopamine transmission in the reward pathway. And as you can see here on the left-hand side, in these healthy control subjects, there's plenty of red, plenty of dopamine transmission in the reward pathway. But if you look at the right-hand column, that is the brain of individuals who have been using cocaine, methamphetamine, alcohol, and heroin for long periods of time in an addictive way. And you can see that there's very little red in their dopamine reward pathways. They are in a dopamine deficit state. They are walking around with a pleasure-pain balance tilted to the side of pain, and this lasts for a long time. These brains are images of these individuals 2 weeks after they have stopped using their drug of choice. 2 weeks, they're still walking around in a dopamine deficit state. And understanding this was really a revelation for me to understand why my patients with severe addiction would relapse even days, weeks, and in some cases, months after they had stopped using their drug of choice. It was because they were trying to restore homeostasis or a level balance. Another really important rule about the balance is that those gremlins, once created, never go away. In other words, the balance remembers. So that means that if I'm walking around and I see somebody, or I'm in a certain place, or I see a thing that reminds me of my drug use, that is a huge trigger for me to want to use my drug. And how does it occur on a brain level? This is an image from a very fascinating series of experiments in rats who were trained to know that if they saw a light, then if they went to a lever and pressed it, they would get cocaine. And what you'll see here on the vertical axis is dopamine levels in the rat's brain. And what the neuroscientists discovered was not only was there a huge increase in dopamine after the rat got the cocaine, but there was a little mini increase in dopamine just when the rat saw the light. So I'm going to walk you through this graph. You see the rat who sees the light. Look at below the line, you see that slight increase in dopamine. That means just being reminded of our drug of choice gets us a little bit high. But look at what happens right after the rat sees the light. Dopamine levels don't go back down to baseline. They go a little bit below baseline. Now I'm in a state of craving. I'm in a dopamine deficit state, which creates an incredible physiologic motivation to go and get my drug, to do the work that it takes to get my drug. And you'll see here that's exactly what the rat does. Goes over, presses the button, gets cocaine, and then has a huge release of dopamine. So this is really important when we start to think about how can we live in a dopamine overloaded world. Part of it is going to be avoiding our drug, but another big part is going to be avoiding triggers for our drug, because the trigger alone can cause this cycle of intoxication and withdrawal, which is exactly the vortex that gets people into the terrible problem of addiction. What happens if we expect a reward and we don't get it? As in this case, you can see the rat sees the light, gets a little hit of dopamine, goes into a dopamine deficit state, does the work to get the cocaine, presses the lever, no cocaine. Look at those dopamine levels way below baseline. And that's true from our life experience, right? When we expect a certain reward, let's say we go to a family gathering and we think it's going to be fun, and it's not fun at all. It's worse than if we had never expected it to be fun in the first place, right? And we go home really bummed out and say, I'm never going there again. All of this is really important because dopamine is also central to the way that we navigate the world around these types of expectations. And of course, if expectations are unmet and we have the disease of addiction, this can function as a stressor and then can drive us to want to use a drug of choice, again, to get out of that dopamine deficit state. We talk a lot about how important it is to prevent the problem of addiction in young people. And there are neurobiological reasons for that. And I'm going to talk about that right here with these series of brain scans. What you see is that at about age 5, we have more neurons than we're ever going to have in the rest of our lives. Why? Because we're like sponges, right? We're totipotent, we're plastic, we're ready to learn. And neurons here are represented by red. But over the course of our lives, we prune back the neurons that we don't use. And until about age 25, we continue that pruning process combined with a myelination process, which is essentially greasing the wheels of those neural circuits that remain. So that by the time we reach age 25, we're left with the neural architecture that we will use for the rest of our adult lives. It doesn't mean that there's not the ability to change. There's still plasticity. We know that we still generate new neurons throughout our lives, but much less quickly. And this is exactly why it's so fundamental to make sure that we try to protect our young people from addiction as a maladaptive coping strategy, and we try to give them healthy coping strategies at this pivotal point in their development when they're creating the infrastructure, the neural architecture that will last them a lifetime. I want to just say, obviously, this pleasure-pain balance is an oversimplification. Dopamine is not the only neurotransmitter involved in pleasure, motivation, and reward. It's a complex constellation of many different neurotransmitters, and we can experience pain and pleasure not just in diametrical opposition, but at the same time. So, for example, spicy food is an example of experiencing both pleasure and pain at the same time. Also, we have these narratives or meaning making that are fundamental to the way that we perceive pleasure and pain. This is a very famous study by Henry Knowles Beecher, who studied the experience of pain in World War II soldiers experiencing severe injury on the battlefield. And to his surprise, he discovered that 2/3 of those soldiers experienced zero pain in the immediate aftermath of their injuries. Amazing. How did that happen? It's because our perception of pain is not just a bottom-up process of nociceptive injury, telling our brain what we feel, but also a top-down process of our brains interpreting what we feel. And these soldiers made two interpretations when they got injured on the battlefield. Number one, hey, I'm still alive. And number two, I'm probably going home. And with that kind of meaning behind the pain was experienced differently. The corollary of that is this very famous case report of a construction worker who jumped on a large nail that went right through his foot. He experienced excruciating pain, was taken to the emergency room, was loaded up on opioids, still didn't get relief, finally was given so many opioids that he became unconscious, at which point the emergency medicine doctors slowly removed the nail, removed the boot, and discovered that the nail had gone right between his toes. In other words, there was no tissue injury. But his brain looked at his foot and he saw an injury and he experienced real pain. So it wasn't that he was making up the pain, but the pain was real and it originated in his brain. Okay, now you have sort of a basic primer on how we process pleasure and pain, how the gremlins work, how they never disappear, how we remember, how even cues can trigger the cycle. Now I want to talk about the ways in which this primitive wiring is incredibly mismatched for our modern ecosystem. So this kind of circuitry is perfectly evolved for a world of scarcity and ever-present danger. What better design than to have us experience pain right after we experience pleasure to keep us striving in a world where basic survival requires us to walk tens of kilometers to get food, clothing, shelter, finding a mate. The problem is that we no longer live in that world. We now live in a world of overwhelming abundance where highly reinforcing drugs and behaviors are at our fingertips, including, as I said, drugs that didn't even exist before and very, very potent forms of old-fashioned drugs. And I would argue to you that the result is not only that we have increasing rates of addiction, which is borne out by epidemiology, showing that rates of alcohol use disorder in women have gone up 80% in the last 30 years. Rates of alcohol use disorder in older people have gone up 50% in the last 30 years. And we have many, many more people now struggling with addictions to things like online pornography, online shopping, social media, video games, you name it. But not only are we seeing increased rates of addiction, we're seeing increased rates of anxiety, depression, suicide. And one of the things that I think is incredibly powerful is if you look at countries around the world and their rates of depression, anxiety, and suicide, it is very clear that the richest countries have the highest rates and the fastest growing rates of depression, anxiety, and suicide. What on earth is going on here? How do we understand that paradox? I would argue that part of the way to understand the reason that we're all growing in our misery is because we're constantly bombarding our reward pathway with highly reinforcing drugs and behaviors. We've drugified almost every aspect of our existence. And the result is that we're walking around in a dopamine deficit state, experiencing the universal symptoms of withdrawal, needing more pleasure to feel any pleasure at all, and feeling injury at the slightest bit of discomfort. So what can we do about it? I hold up people in recovery from severe addictions as modern-day prophets for the rest of us to how to navigate this dopamine-saturated world. And this is an acronym that I'll just very briefly go over, but the pivot point of this acronym is the A that stands for abstinence. What I have come to do in my psychiatric practice, whether the individual is coming in with addiction or whether they're coming in with anxiety and depression, the first thing that I will do is screen them for compulsive overconsumption of highly reinforcing drugs and behaviors and suggest to them an experiment. And the experiment goes like this. Try giving up this drug of choice for a month. Why? Because in doing so, you will allow enough time for the neuroadaptation gremlins on the pain side of your balance to hop off and for homeostasis to be restored. And only then will you be able to get joy in more modest rewards, and only then will you be able to see true cause and effect, which is that compulsive overconsumption of these drugs is actually causing your depression and anxiety. Many of my patients on first pass are highly skeptical of this hypothesis. They say, Dr. Lembke, my video games are the only thing that alleviate my depression. Dr. Lembke, smoking pot is the only thing that works for my anxiety. And what I say is, I hear you that in the moment, it feels like you are self-medicating your psychiatric problem, but I would posit to you that what you're really doing is just temporarily restoring a level balance while you're accumulating more gremlins on the pain side of the balance. Of course, I would never recommend this intervention for someone who is at risk for life-threatening withdrawal from alcohol, benzos, or opioids. I would not recommend this intervention in someone who had repeatedly tried to stop on their own and was unable to. Those individuals need a higher level of care and more support. But for the vast majority of the patients that we see in our clinic, this first pass intervention can be not only instructive but highly healing. So how do we get them there? The first pass is just to gather data. This is where we ask patients to tell us, what are you using, how much, and how often? And the simple act of putting into words what we are doing in terms of our consumption can have a revelatory impact on our understanding of what we're doing. Because as long as it stays in the dark recesses of our minds, we can minimize it and we don't have to look at it. But when we tell another human being, it becomes real in a way that it otherwise cannot. I ask them, patients, what's your objective for using? Why do you use? And again, this is because many times people will endorse they use for one of two reasons, to have fun or to solve a problem. But as they get into the addictive cycle, what happens is that their initial reason for use gets very far away from their original reason for use. But nonetheless, important for us to understand what their rationalization is. Then I ask patients about problems. What are the problems you note with use? And sometimes with young people, the only problem they will endorse is that their parents aren't happy with their use. But that's enough if they have an alliance with their parents and they want to make that better. Then I recommend this 4 weeks of abstinence, or if you can't do 4 weeks, do 2 weeks. If you can't do 2 weeks, do a single day, especially when it comes to digital drugs. Put that phone away for 24 hours. But in general, the data, however limited, shows that it takes on average 4 weeks of abstinence in order to reset brain reward pathways and be able to experience pleasure in more modest rewards. If patients don't do the 4 weeks, once they're already addicted, all they're experiencing is withdrawal, right? Remember the balance. You take away the pleasure weight, those gremlins weight it down to the side of pain. And in those first 2 weeks, patients are in withdrawal. So I warn them, you're going to feel worse before you feel better. You're going to experience the universal symptoms of withdrawal, anxiety, irritability, insomnia, dysphoria. If you can just get your way through that, you will eventually feel better in weeks 3 and 4. And for about 80% of my patients, which is consistent with the scientific literature, they do feel better at 4 weeks. For those who don't feel better, that's really important data, right? That tells me, okay, your compulsive overuse isn't the primary driver of your anxiety, your depression, your psychosis, whatever it is. I always talk about mindfulness. What is mindfulness? It's a word we throw around a lot. Mindfulness is essentially the ability to observe our thoughts and feelings without judgment and without reaching for our drug of choice to get out of that space of discomfort. So doing this experiment is a really wonderful opportunity to learn and practice mindfulness. So it's important for patients to understand what that means and to realize that even intense psychological discomfort is time limited. Tincture of time alone will often heal this process. It can pass over us like a wave. And if we can separate ourselves from our thoughts and emotions and watch ourselves go through the experience, then we know that it's time limited. Insight is the point that when we get away from chasing dopamine, we can see true cause and effect. And often I will have patients come in and say, you know, Dr. Lembke, I really thought that this cannabis was treating my anxiety. It's only after I stopped it for a month that I realized that the cannabis was actually driving my anxiety, or the video games, or pornography. Behavioral addictions are addictions that don't involve a drug. What do I do for pornography? I say no watching pornography, but also no orgasms with yourself or anybody else for a month, right? As a way to, again, reset reward pathways. And resetting reward pathways is key to be able to have the cognitive and emotional strength to do what's next, which is decide next steps. Am I going to go back to using this drug, or am I going to continue to abstain? And either way, how am I going to do that? And then we talk about self-binding strategies. And what do I mean by that? Self-binding strategies are barriers, both literal and metacognitive, that we can put in place to put the brakes on desire. And they are absolutely fundamental in a world in which we're being constantly tempted to indulge. Self-binding means things like not keeping your drug in your house, or not keeping your drug in your room, or making sure if you're going to use in moderation, you only use on special occasions, and then don't populate your calendar with a special occasion every night. I have a young man addicted to video games, and he came up with a bunch of great self-binding strategies. One of them was that he was going to have one laptop for video games and one laptop for schoolwork. And that way he had a state-dependent learning, that he didn't mix the two. He decided there were certain video games he couldn't play at all, like League of Legends, because once he started, he couldn't stop. He committed to playing only 2 hours a day, only 2 days a week, so he used time as a self-limiting strategy, and he committed to playing only with friends, never with strangers, and thereby made his recreational use of video games something that could extend into positive use. Finally, in the last minute, I want to talk about one other strategy, which is very counterintuitive and paradoxical, but this really works, and it gets back to the balance. It turns out that those gremlins are agnostic to whatever the initial stimulus is. So if we press on the pleasure side by ingesting intoxicants in any form, those gremlins will hop on the pain side to try to bring us level again, tilting us to pain, and then hopefully back to homeostasis. But if we press intentionally on the pain side in mild to moderate doses, guess what? Those gremlins hop on the pleasure side. And with iterative repetition, we'll eventually reset our pleasure-pain balance to the side of pleasure. This is the science of hormesis. Hormesis is Greek for to set in motion, and what we're essentially doing there is using mild to moderate noxious stimuli to trigger our body's own healing mechanisms by upregulating dopamine and other feel-good hormones and neurotransmitters in response to these minor toxins or injuries. So when patients are trying to abstain for those 30 days and struggling in the moment, a lot of times we think, well, if you're uncomfortable, do something to make yourself comfortable. If you're trying to quit eating sugar, go binge on Netflix instead. But what I say to my patients is, there's a big risk of cross-addiction. If you give up one drug and replace it with another, you may get addicted to that other drug. But how about instead of, when you're feeling craving, reaching for another drug, do something that's harder or more uncomfortable or more painful than the pain that you're feeling in the moment, like exercising, like an ice-cold water bath, like making any effortful engagement that forces you to press a little bit on the pain side of the balance. Now, can people get addicted to pain? Absolutely. Have I seen people addicted to exercise? Yes. Have I seen people kind of getting addicted to ice cold water baths? Absolutely. Do I see people cutting on themselves, which releases endorphins, and get addicted to that process? Yes, I do. So we're not talking about hitting that pain side really hard and really fast. We're talking about mild to moderate adaptive forms of dopamine. In other words, we're talking about paying for our dopamine up front so that we don't have to suffer from the dopamine deficit state that comes from paying for our dopamine after. I hope this has given you some practical tools for how to survive in a dopamine overloaded world. Thank you.
Thank you. What an enlightening talk. Again, if you would like to pose questions to Dr. Lembke, please do so via the QR code that's found in your program or on the screen if you're online. I see that we already have a few questions. And so first questions we have from the audience is everybody susceptible to the dopamine high, or are some more susceptible than others?
Some are more susceptible than others. The risks of addiction can be broadly categorized into nature, nurture, and neighborhood. When we talk about nature, we talk about the inherited risk, which is about 50 to 60% of the risk of getting addiction based on family studies of people with alcohol use disorder. So we don't really know it for other drugs. But if you have a biological parent or grandparent who is addicted to alcohol, you are at increased risk of developing an alcohol use disorder yourself, even if you're raised outside of that alcoholic home. Also, in terms of nature, if you have a co-occurring mental illness, you are at increased risk of developing an addiction. In terms of the nurture piece, we know that children who are raised in an environment where parents explicitly or implicitly condone substance use, those individuals are at increased risk. Whereas being a helicopter parent and knowing where your kid is and what they're doing decreases the risk. But I just want to say I have seen children from absolutely perfect, wonderful families get addicted, and I've seen people from really traumatic environments who never get addicted. So this is never a one-to-one. That last bucket of risk is something that we seldom talk about, and it has to do with neighborhood or environmental context. We know that poverty increases the risk, unemployment increases the risk, but here's one we never talk about: access. Simple access to a drug increases our risk of trying that drug and getting addicted to that drug. And one of the big points I'm trying to push home is that we are living in an addictogenic world. The increased supply and access to all kinds of reinforcing drugs and behaviors has really increased the vulnerability profile for all humans living in rich nations. The most vulnerable among us are probably poor people living in rich nations because they have more disposable income to more cheap sources of dopamine without having equal access before the law to healthy forms of dopamine that come from things like being in nature.
Thank you. Second question, is meditation effective in retraining dopamine regulation?
So meditation is something that requires effortful engagement, and it has been shown to increase dopamine levels. And I would consider it, although we don't think of meditation as painful, it is effortful. It can be painful, especially as we experience a flooding of thoughts and emotions that we're forced to sit with and not run away from. And so in that sense, meditation is a potentially healthy and adaptive source of dopamine, as is things like prayer or other mind-body work.
We all have smartphones. Our kids have smartphones. What can we do to curb our addiction to these devices?
I really recommend a 24-hour dopamine fast from all digital devices. If you haven't tried it, I urge you to go out and try it. Do it together with your partner. Do it together as a family. And as you do it, make sure that you know what to expect, which is that in the first part of that dopamine fast, your pleasure-pain balance will tilt hard to the side of pain, and you will experience that as anxiety, irritability, fear of missing out, fear of an emergency that you need to be called on to fix, right? That's the kind of parental piece of it. Well, I have to be available in case some disaster happens. But as you go through the course of that dopamine fast, notice how those thoughts and feelings abate. Notice that the amount of mental real estate being occupied by your phone starts to diminish, and you experience a kind of freeing and a kind of recognition that you don't have to be tied to these devices in the same way. I also really recommend that if you notice that your child is having problematic use, that you discuss with that child, especially a younger child, taking their device away for a period of time and having the return of that device be contingent on other types of behaviors. I've worked with a lot of families. It's so hard to do this. I've done it in my own family with our younger child because he was on his phone during class, failing his classes. It's so hard to take that phone away, right? They say everybody has a phone, I'll be cut off. You explain why you're doing it. You note that your child goes through all of those horrific temper tantrums at first. And then what I see in families and in children is over the course of that month, kids start to return to who they used to be. One of the most amazing things is how they retain their ethical compass. They begin to care about the people that they live with again, to notice jobs around the house that need doing without our having to ask. So I really urge families to either do it together as a family or do it for your child who cannot help themselves and see what the difference is. And the key there is once your child sees how much better they feel and better they function free of their device, then they're motivated to use their device in a different way. You no longer have to berate them and convince them of it.
Be great to try that maybe tomorrow before Monday comes. Screens are easy babysitters these days. Has any research been done on screen addiction for children under 5?
There's lots of research on screen addiction now. A big problem is how exactly to quantify that or assess for it or diagnose it. Broadly speaking, again, addiction is the continued compulsive use of a substance or a behavior despite harm to self and or others. What I can tell you is that the early prophecy of giving a child, a very young child, a screen in order to make them a baby Einstein is not scientifically validated. And in fact, what's probably true is that the younger we expose our kids to screens, the harder it is going to be to have them develop other healthier adaptive coping skills later in life. So I really urge parents, while you still have control over your kids, minimize their screen time and make sure any screen time that they have is supervised so you know what the content is. Do not give your unsupervised child unlimited access to the internet. And then when you do finally entrust your child with their own device, make sure you talk about digital etiquette. Make sure you talk about the harms and risks of addiction to these digital drugs.
Great, thank you. Can you recommend resources for parents to share with adolescents to explain the pain-pleasure phenomenon? As a parent of a gamer, we are not having luck explaining it to him.
Well, I mean, at the risk of self-promoting, I have written a book about this. So you might read the book first to see if it's appropriate for your younger child. I do talk about a lot of different addictions in the book, including pornography addiction. But there's also a lot of good material online. YouTube videos, I'm suggesting YouTube videos. But there are some very good videos talking about what happens in the brain as we go through the process of addiction. And I can tell you that a lot of people come to me and they're sort of skeptical. Is sex addiction real? Is video game addiction real? I can tell you in the last 20 years of practice, I'm seeing growing numbers of people addicted to these digital drugs. And it is very real. The natural history of their addiction is exactly the same as addiction to drugs and alcohol. They increase their use over time. They need more of the drug, more potent forms of the drug. It starts to affect their mood, their motivation. They become suicidal, despondent, incredible shame. And then when they get away from that drug and abstain for long enough to get their prefrontal cortex back online and to reassert homeostasis, they feel so much better.
Has nicotine addiction been proven to be a physical dependency, or are smoking and vaping providing more of a dopamine trigger?
I think this question is the nicotine itself addictive versus the delivery mechanism? Nicotine is a stimulant. It certainly is addictive, but it's also been looked at as a possible agent to help people with depression. So, at lower doses, nicotine itself may not actually be that harmful, but it's the delivery mechanism through the vape and through the cigarette that makes it so incredibly harmful, not just because of the lung health harm from the delivery mechanism, but also because the levels of dopamine, of nicotine achieved, especially through vaping, are so incredibly high that any potential therapeutic benefit of nicotine is superseded by the nicotine itself. And let me just say that nicotine is highly addictive. And the withdrawal phase is very, very quick, many, many times through the course of a day. People get intoxicated, go into withdrawal, need another cigarette, get intoxicated, go into withdrawal. And of course, when we think about nicotine intoxication, we don't really think about that as the way we do with intoxicants like alcohol. But remember, what you get is a little bit of a stimulant boost, and then you're very quickly in withdrawal. And then your entire being is hijacked by the preoccupation with the next cigarette.
Right, thank you. Time's gone by so quick. This will be our last question. What would you suggest if we suspect a friend or a family member suffering from a dangerous addiction? What might be the conversation starter we could use?
The first thing that I recommend is that you don't talk to your loved one when you yourself are emotionally dysregulated. So, for example, don't do what I do, which is scream at my 14-year-old about getting off of Minecraft after I've been asking him to get off for 2 hours and he's still on. And I'm feeling like a bad parent. I'm thinking he's a bad kid. I'm worried about his future. I'm worried about his present. Don't do that. Don't make that mistake. Instead, wait till a time when you yourself are emotionally regulated, you've thought it through. If you're co-parenting with a partner or it's a spouse, or you can enlist a child, do it together without feeling like it's an ambush, and sit down and just reflect back to your loved one what you are seeing. This is a little bit like the D of the dopamine acronym, the data part, where we try to reflect back to people what we see are the negative impacts of their use, as well as the raw data of quantity and frequency, which they literally cannot see because they are chasing dopamine and it's hidden to their conscious awareness. And so don't try to come up with solutions necessarily in that first engagement. You can express your sadness, but really keep it a kind of even keel. This is what I'm seeing. I really love you. I really care about you. And I'm worried about you because this is what I'm seeing. And then don't expect immediate results. A lot of times when I'm working with our trainees who come and spend an extra year to learn about how to treat addiction, God bless them, they'll say, Dr. Lembke, I don't feel like I helped this person. And I'll say to them, you never know. I've had patients I thought I didn't help who went out, didn't come back, and then came back 2 years later and said, Dr. Lembke, when you said that to me, I thought about it a year later, and I decided that I was going to come back and get help. So when we say what we need to say to our loved one, say it and let it rest. Say it and let it rest. Let it marinate and see if they will then do something with that. I will also say that contingency management works. There's an enormous amount of data around contingency management. What is that? That's the use of rewards and punishments in moderate doses to shape behavior. So working with your family around contingency management can be very effective. And what that looks like is you can get your phone back or your video game console back once we see this type of behavior for this period of time.
Great. Let's thank Dr. Lembke for sharing all these wonderful tips.